itself to education, interaction, teaching, and certainly benefiting the young interventional cardiologists of the Asia-Pacific region through these monthly seminars and webcasts, which clearly bring the best of Asia-Pacific region to interact with some of the thought leaders from the West. And today you can actually see some of the exciting topics which are going to be covered today. It's a pleasure to tell you all that we have a record more than 3,300 registrants today. So it certainly promises to be an exciting interaction and perhaps will benefit a lot of audience who will log in for the next 2 hours. We're definitely going to try and stick to time. It is certainly the responsibility both of the speakers and moderators. And while we want enough time for the discussions and for everyone to be able to participate in the discussions, I hope that we will actually leave every session with clear practical take-home messages to benefit all listeners as they go into the cath lab tomorrow or on Monday. I think that I'm going to take this, the privilege of starting off the session by the first session, which is on practice pearls from the experts. And we have here to discuss on the EBC consensus, none other than Goran Stankovic. Goran Stankovic is the professor of cardiology at Serbia, Belgrade. He's a thought leader with a long experience. And of course, he's been an integral part of the leadership of the European Bifurcation Club. Much of what we understand today, much of what we practice today for bifurcation lesions, including left main bifurcations, have been some of his seminal researches which have gone into publications and then leaded to consensus statements which have come out of the European Bifurcation Club. So he's led this field for a long duration. And there could be no better person than him to interact, to clarify our thoughts, clarify our doubts, and also get the messages of the European Bifurcation Club. As you know, the bifurcation clubs do exist across the world in various regions, each having partially different philosophy from the others, but always meeting at some point where we agree to whatever has been coming out of the various trials and policy documents. So with that, I would hand it over to the first topic. My colleague, my co-moderator is Cheem, and we actually have discussions with Ravinay Bhindi, Lim Sutek for this symposium. So over to you, Goran. So I hand it to Goran. Goran, your sound is muted. Yes, you're on now.
I'm really sorry. Good afternoon, Professor Seth, Professor. Thank you very much for privilege to address with a presentation on EBC consensus on left main PCI, practice pearls. And I don't have any conflict of interest to disclose related to this presentation. But I will start presentation as EBC board member and current president with our ethos for treatment of all bifurcations. And what we recommend is keep it simple and safe, try to limit the number of stents, respect the original bifurcation anatomy, and try to reproduce it. Aim for well-opposed and well-expanded stents with limited overlap, but of course, the elective treatment of bifurcations with complex anatomy and diffuse involvement of both branches usually requires two-stent approach. I cannot move my slides, I'm sorry. So I would like to use this opportunity to clarify when we speak about provisional stenting as the standard approach for treatment for vast majority of bifurcations, including left main. When we say provisional stenting is a treatment strategy or philosophy rather than technique. So when we speak about culotte, when we speak about tap or DK crush, these are techniques. But when we speak about provisional, I would like to really clarify that this is a treatment philosophy. We start with main vessel stenting, trying to respect distal main vessel diameter, and finalized with pot to respect the original tapering anatomy, and of course trying to open the struts towards the side branch. At that level, we reconsider whether or not side branch is compromised. If it is, we continue to dilation. And after that step, if it's still compromised, an escalation to side branch stenting is facilitated. So when we say provisional, this does not mean one stent strategy. And this is one of the mistakes that really need to be clarified in the literature and in our discussions. I'm speaking about left main, and left main has specific anatomical characteristics which make it different. Large main vessel with a huge caliper discrepancy between proximal and distal part of the main vessel. It's most frequently T-shaped angulation according to CT. Angulation between LAD and circ is approximately 80 degrees. Is the area very prone to calcification? Ostium could be frequently involved with fibrotic issue, and side branch is never small. Circumflex is the side branch, and we have trifurcation in approximately 10% of cases. And this has impact on stenting technique. Because of caliber discrepancy, proximal optimization is really mandatory step, and we need to know and consider state design. And with stent design, when I mean it's open cell design and maximum expansion capacity, which will be able to accommodate up to 6 millimeter, which is according again to CT mean value of the reference diameter in left main. Because of the open bifurcation angle, we need to think about stent over expansion, and especially if we select two stent techniques, we need to take into account deformations like in culotte, when you overexpand the stent towards the circ if you have 90-degree angle. Because of ostial involvement, we need to take into account elastic recoil and of course the risk of longitudinal foreshortening. And because of calcification more in the arbor area, lesion preparation is key if we want to optimize procedural result. We published 2 years ago consensus document specifically dedicated to left main PCI, and this is, I think, the key sentence. In left main disease involving both branches, stent technique should depend on individual patient's anatomical characteristics, but of course needs to take into account operator experience and skill. And it's our general approach that for majority of left main bifurcations, provisional strategy should be effective. And these are the key steps according to EBC consensus. So wire both branches, predilate main vessel, and we'll let operator decide whether or not he will predilate side branch. We have some evidence from a randomized trial of manual PAN that side branch dilatation is better for procedural TIMI flow in the side branch. So we should not neglect possibility in diffuse disease, especially in calcified circumflex, to predilate side branch. Then we stent main vessel according to LAD ostium. Proximal optimization is mandatory step, and then we recommend optional to do pot, kiss, pot at that level, and if necessary, we evaluate result, and then side branch stenting, if performed, kissing becomes mandatory step. This is just illustration from the visible heart, how huge discrepancy in the ostium of the left main we have if we select stent according to ostium of the LAD diameter, but after performing proximal optimization with adequately sized balloon, we really, according to OCT, reach optimal expansion. And for POT, I think it's important to know devices in your lab. It's important to select either semi-compliant or compliant balloon. By increasing pressure in the compliant balloon, you actually increase diameter and POT becomes more efficacious. Kissing is a big issue for left main PCI, and this is our analysis of the impact of kissing in provisional and two-stent strategy. This is combination. Some of the studies are also in the left main, but not all. But if you may see, please pay attention to the first column. This is actually like a traffic light system. And in provisional, the only study is a COBIS-2 registry, which shows positive impact of routine kissing in provisional. And then we have COBIS-1 with negative impact of kissing in provisional. But most other published studies, including Nordic 3 randomized trial, show neutral effect. So kissing does not improve, but also there is no penalty if you perform kissing for large side branch like the left main. In two-stent strategy, all published studies clearly document positive impact of kissing on clinical outcome of our patients. So for two-stent strategy, we have clear answer. Kissing is mandatory step, while for provisional, we should take decision for individual case. And if we decide to do kissing, this is how European Bifurcation Club suggests to do it. So we recommend short, distal main vessel and side branch reference. We suggest to start by inflating side branch first in order to remove metal from the ostium of the side branch, and then alternate up to 12, 14 atmospheres, then decrease pressure in the side branch balloon and increase pressure in the main branch balloon. Longer inflation, according to bench tested, is strongly recommended. Unless we keep balloons inflated for 30 seconds, there is huge recoil in the metallic structure, so we need to either keep balloons for 30 seconds or we need to repeat 2 or 3 times 10 seconds and then simultaneously deflate both balloons. Final single proximal inflation is mandatory for left main if you cover the ostium, because with second pot, or actually more precisely final proximal inflation, you actually correct longitudinal deformation at the ostium of the left main stent. And this is my cartoon, which I prepared just as illustration for your attendees. And this is how we do left main according to EBC recommendation. So we select stent according to LAD ostial diameter. You see it's not deployed adequately. We need to do pot, and we need to do pot up to the ostium. We cross distal cell, we do kissing, and after kissing we have to repeat pot in order to correct a longitudinal deformation created by the guiding catheter. And this is fly-through animation, which shows that by doing these steps, we widely open access to the side branch, and we actually create like natural fractal geometry with larger diameter proximally and smaller diameter distally. And this is just one of my cases as illustration of the philosophy of EBC left main PCI. So 62-year-old patient, no risk factors. She was admitted with acute coronary syndrome, positive troponin. We brought her to cath lab. This is right coronary artery, no major lesions, but you see clear collateralization towards the LAD and circ. And this is the first angio of the left main. You see a really complex anatomy. We used femoral approach in this case. And this is how in this complex anatomy decision-making was done. So we try to understand plaque distribution. This is the contour of the lumen. And in my interpretation, this is a vessel contour. So most of the plaque, although it's a huge plaque burden, is actually in the lateral wall in front of the ostium of the LAD. So in my view, single stent strategy from the ostium into the LAD will push that plaque, will not compromise circ and marginal, and I believe provisional as a philosophy, as a strategy is a good to start. So these are the diameters. If we don't have imaging, in this case, you can do after predilatation imaging, of course, but you can also calculate according to Murray law that with 3.5, 3.5 for the circ and LAD, approximate left main is at least 4.6, 4.7. So it was difficult to wire the LAD. We had to use venture catheter monorail. And after wiring all three branches, we predilated towards the LAD. And after that, we stented according to, again, standard protocol. First in apicodal, we correct the coverage of the lesion in the LAD. Then we go to apicranial or shallow LAO to cover the ostium. And after that, this is the result. And as expected, there is plaque burden, which was shifted towards the circ, but without significant compromise. We performed 4.5 by 10 NC post-dilatation. And after that, we exchanged wires and we did kissing or tracing with 3 wires. And this is the result after kissing with provisional. And final result really confirmed that careful procedural planning and understanding distribution of plaque really can help, starting with provisional strategy, and then if necessary, of course, we can easily put second stent. And this is consensus. If we need two-stent strategy, we believe two-stent strategy as an elective strategy should be used for long circumflex disease or high risk of circumflex compromise. But even in that case, we can start provisional stepwise approach and finalize procedure with T, TAP, or culotte. And this is METS2 classification showing that after provisional, we can use, depending on experience of the operator and the anatomy, T, TAP, or culotte. And the main difference is how we estimate the risk of losing the side branch after main vessel stenting. So if we don't expect very high risk of losing the circumflex, we recommend provisional side branch stenting strategy. But in case that we expect high risk of compromising circ, of course, if you are experienced operator, you can start with decay crush, or you can do stenting from the left main into the circ, like inverted provisional, and then again finish with inverted culotte, TAP, or T stenting. And this is the main difference between T and TAP. It's actually, if you don't protrude, if you cross the distal cell, you can do T stenting without metallic neocarina. But if you have narrow angle, you need to pull back your stent partially inside the main vessel stent, and you have this metallic neocarina, which after finishing procedure with kissing is repositioned in the center, which is very important for the flow pattern. I'm sure Professor Chen will speak about decay crush as best strategy for left main. We have evidence from one trial, decay crush 5, but I'm only pointing your attention to QCA data. Circumflex disease was almost 17 millimeters in this study. And if we go even to the more recent publication of definition 2, side branch lesion was 20 millimeters. So I think decision to start elective two-stent strategy should be based on length, diffuse of disease, and clinical relevance of the side branch. And if we have 20 millimeter disease of the circ, but we know from Benesten study that stent is better than balloon. So in my view, results of decay crush 5 and definition 2 are clear and expected, because for such diffuse disease, balloon does not work. We just need to decide whether we will start with decay crush or with provisional and then finish with T-TAP or culotte. This is for me the question. But whether two stents are better, it's clearly for that kind of diffuse. In everyday practice, the most recent trial, contemporary on left main Excel, however, shows that in general, 3 years adverse outcome is worse for two stents compared to provisional. You see death, MI, and stroke. You see, even if you add ischemia-driven revascularization, that there is difference in favor of provisional, and European Noble shows exactly the same. So there is EBC main comparing provisional according to criteria that I just explained, versus dual stenting strategy left to operator discretion of the operator. And we believe that planned provisional rather than planned dual stent strategy will be better for large circumflex with diffuse disease. I'm happy to report that we completed enrollment 1st of December last year. I congratulate the best recruiting centers, and I'm happy to share with you beginning of next year the results. So, dear colleagues, I would like to conclude that in my view, and I'm sharing EBC consensus document with you, provisional is recommended for majority of bifurcations, including left main. Stenting technique should be based on individual patients' anatomical characteristics and the skill of the operator. Two stent strategies should be considered for important side branch with complex and extensive disease according to definition to study for difficult side branch access or high risk of compromise. Among two stent techniques, there is at the moment strong randomized evidence in favor of DK crash, while EBC main results are awaited. I thank you very much for your attention.
Thank you very much, Goran. I hope I'm not muted. No, I'm not. I think that was a great overview. And we have 10 minutes for discussion. This is going to be very relevant. I would just state that before I pass it on to Ravinay Lim, as well as Stan Cheem, I just state that actually the issue is not about one single stent strategy or provisional strategy versus two stent. It is which patients should have a single stent strategy and which are the ones who do best with the two stent strategy. And I think there is really, that's what definition study was all about, because definition study, of course, had an extreme criteria going on one side. On the other side is the fact that we do have single stent strategies for nearly 75% of the patients. But my question to you would be, Goran, that clearly the decision about intervening following provisional stent strategy and definitions nearly demonstrated that and you may end up actually stenting the side branch in 25% of the patients, 20%, 30% of the patients. And when you actually have a situation where you fill yourself out with a second stent, or you have then gone into a situation may not be an optimal result. Does that influence the feeling?
To be honest, you know, bailout stenting, of course, is a rare situation.
Bailout, a second stent as a bailout.
Yeah, second stent as a bailout has the risk as any other bailout bifurcation anywhere in the coronary tree. Of course, in left main, level of adrenaline may be slightly higher, but by planning strategy, if I see diffuse disease in the circ, if I with stenting of that dissection, I'm not going to leave unstented dissection in large circ, trying to forcefully stent left main towards the LAD. One of my favorite approaches in large circumflex is to stent from the left main into the circ. So it's again provisional. That's why I say provisional strategy compared to DK crash, which is stenting from the ostium of the circ. We stent from the left main into the circ, we do pot, we do kiss, and if we need second stent in the ostium of the LAD, we can use again T-tap or culotte. So it's philosophical approach, which is different from stenting only the ostium of the circ and then putting stent in the main vessel. I don't think that there is main difference in clinical outcomes which makes one strategy more clinically acceptable than the other. I believe that if you optimize result, and we strongly recommend it because of the time I didn't speak about imaging, for left main PCI, EBC strongly recommends image guidance, and especially if you have diffuse disease like in my case, I think use of imaging may help in the earlier stages of career to understand vessel diameters, plug distribution, whether there is calcium or not. So bailout stenting should not be the main determinant to stent side branch first, in my view. I think that stenting from the left main into the circ, in that case, can provide equal results. And don't forget that in definition too, you have 25% of culotte and 70-something% of DK crush. So it's not purely DK crush versus provisional.
Over to Ravinay and Lim, comments and Cheem.
So I think Goran's touched on a few really important points. The first is the role of imaging. Sometimes the angiography doesn't give you quite a good appreciation of plaque distribution and plaque severity within, for example, the ostium of the circumflex. On angiography, the circumflex might look mild. And so I think performing imaging beforehand really gives you an idea as to what stenting strategy you deploy, whether it's a 2-stent or 1-stent strategy. The way the plaque's distributed, the calcium distribution might influence your debulking strategy to get a good expansion and good result. And I guess secondly, perhaps understated by Goran, is the importance of using what technique you're comfortable with. I think we always look at all these different strategies, but ultimately you've got to be comfortable in executing your strategy with elegance and ensuring you maintain the coronal shape at the end, true to the anatomy you can. So I think the importance is understanding the anatomy, planning it, and using your strengths. Bifurcations account for about 15% of our practice. Depending on your volume, you need to be used to a certain technique. Ensure the angles might determine whether you use a culotte or a DK crush or a tap. But I think you've got to be comfortable with your technique to get the optimal result.
Yeah, I cannot agree more. I agree with every single word that you said.
Lim, yourself?
Yeah, I think Goran stressed the importance of this provisional standing as a philosophy. I think that is very important in the understanding of the approach. And on top of what Ravinay said, I think it is said that most operators are recommended to master at least 3 2-stent bifurcation stenting technique. One is the DK crush, one is the culotte, and another is the T that technique. I think mastering these 3 will allow the operator to tackle most of the left main distal bifurcation lesion. And of course, the stratification of the lesion complexity using either definition criteria or some other criteria on top of the Medina classification will be important in the planning of the strategy. And Goran has outlined some of the situation where the 2-stent technique should be considered upfront. I think those are very important considerations. Thank you.
Can I just add something? I agree, of course, but we continue speaking about imaging should be done, imaging should be done. IVUS does not work as intention to treat, so you need to react according to what you see. And when we discuss between experts cases, we really need to say, I used IVUS and I use 1 millimeter bigger non-compliant balloon for POT or for final post-dilatation. I use higher balloon pressure. I think that by using IVUS, we are not giving clear message, because we need to use IVUS and then say, based on IVUS, I decided this, and that. And my malapposition that was present after before IVUS was corrected by using 1 millimeter 5.0 balloon at the ostium of the left main. And I would like to again stress, when we say provisional, provisional is not 1 stent. Provisional is just stenting main vessel first, evaluating the result, opening the side branch, evaluating the result, doing kissing, evaluating result, and then putting 2nd stent with T-tap or culotte. I think this is different, because in most lectures, they always say, when I speak about provisional, they say, okay, single stent. It's not single stent. It's sequence of decisions, and I think it's very flexible and very adaptable to result at each level of the procedure.
So Goran, just briefly, and this is going to be the last question for you, but for you to stay on because there's got real great discussions coming up, and your input would be required in almost all the discussions going to happen. The brief answers to certain questions which the audience would certainly want to hear your answers. Which lesions? Is it totally the definition criteria that you follow for deciding upfront two-stent strategy versus provisional, or is it something else that you decide? The definition criteria is fairly advanced.
It's fairly clear, but another indication for me to start stenting from the left main into the circ is awkward access, unfavorable access of the circ. If you spend 15 minutes to wire that circ, I think it's better to start by stenting immediately, securing that one. So in addition to definition, which is, I think, clear for everyone, awkward access and the risk of losing the circ, if I estimate at the beginning it's difficult, I think it's better to be flexible and stent towards the circ.
And the second point is, in the provisional strategy, when do you decide that you need to send the second stent, the side branch, as say as a salvage procedure? I'm not saying you have, of course, an occlusion of the side branch, etc. What makes you decide?
I don't hear you, Ashok, completely, but I guess what are the indications
on your
for
results of a provisional strategy?
Yeah. So
I mean, after
this is again partially philosophical approach. If you would like to finish with provisional, you need to understand that you need to accept in advance suboptimal result at the ostium of the side branch, but not something that compromises the flow. So you should not decrease TIMI flow. You should not decrease 50% stenosis or 70%. In left main, I think the threshold is much lower, and if I don't achieve with kissing adequate angiographic result, I will put second stenting in circ more frequently. Outside of the circ, I don't think that we have any documented study confirming the benefit of stenting unless we have 90% lesion in the circ or diagonal branch. That's the indication for second stent. Based on all meta-analysis of all randomized studies, at 3 to 5 years of follow-up, more metal is not good for overall mortality. You have 20 to 30% higher mortality rate with more stenting because I guess it has impact on flow characteristics and also on the movements and rotation of the heart. So we put 2 stents when it's necessary, but we try to limit as much as possible.
Okay, I'll pass it over to Cheem to take on the second part of this session. Cheem, over to you.
Thank you very much. I think that was a good concluding remark from Goran. So I'd like to introduce our next speaker, Dr. Chen Shaoliang, who obviously is the pioneer of the double kissing crush technique. And Dr. Chen is online now and he's going to share with us best practices from best outcomes. And we all know he's from Nanjing People's First Hospital in China. So Shaoliang, the stage is yours. Shaoliang, can you share your slides? He has been having problems, logging onto the video.
Oh, thank you, Huay. Can you see my slides?
No. But
hello, Huay. Yeah, no, can you see?
Yeah. I can see the slide.
Okay, no problem. Can you see my slides?
No.
No? Okay, let me. So now can you see my slides? Still no? Sorry.
No.
Still no. Still no.
Okay. Can you see my slides right now? Still not? Oh.
No.
Not.
Okay. Give me 1 second.
You may want to log in and out, and again it'll come in if you.
Now can you see my slides?
Still cannot.
Hello, Ashok.
No, we can't.
Yeah, Ashok, can you see my slides right now?
No, Shaoliang.
Still
But
cannot?
No, but we know that you're screen sharing. But
I'm sorry.
It's okay.
I don't know what's wrong with my slides. Okay, I will reshare my screen.
Yeah.
Can you see now?
Still no.
No.
Can you see now?
No.
Yes, you started sharing, so just wait for some time.
So maybe if you log in again.
Hello?
Hello, Shaolin, can you hear us? Can you hear us?
Oh my God.
If sometimes you log in again, you'll be better off.
Hello. Yeah, I can hear you.
Now we see something.
I can hear you.
We saw a part of your screen come on just now.
Okay, let me do it. I think probably there's some problem.
Are you logging in again?
Perhaps we can go on to the next session and then come back again to Dr. Chen Shaoliang.
Shaolin, can you hear us? So can he hear us?
No, Ashok, your signal is quite patchy. Staying with whether we can go on to session 2 and then we come back to Dr. Shaoliang afterwards.
We can do that. If he can hear you, that would be good.
Yeah, I think we have lost him actually.
Okay, but you can hear me well?
Yes,
now
yes.
I can hear you.
He's
okay,
here.
then that would be good. And I think we should proceed to answering your dilemmas this next session. And I hand it over to Dr. Upendra Kaul and Dr. Akasaka Takashi.
Well, good afternoon, everybody. And let us start the session number 2. And this session is answering your dilemmas, some very important topical issues whenever one is doing a bifurcation stenting, especially when one is handling the left main. And one of the very important things is whether we should go for angiography alone or use other imaging modalities like intravascular ultrasound, OCT. OCT we know has some limitations in the imaging of left main, and also the flows, and that will bring in the physiology. So let me straight away ask Dr. Sangathavelu to address the issue of how do you assess the severity of left main lesions by imaging, physiology, or both.
Hello everyone, can you see my slides?
Yeah, we can see the slide very well.
Thank you, Dr. Kaul. So addressing severity of left main, whether it's imaging, physiology, or both. So we know that by angiography has significant inter-observer variability, and we also need to have ischemia documentation before we revascularize. There are not many randomized control trials supporting physiological assessment in left main, but there are non-randomized trials and meta-analysis which confirm a favorable outcome when we use FFR for decision making. And FFR more than 0.80, same cutoff for non-left main, is safe, more than 0.8 is safe to defer revascularization in isolated left main disease. As far as imaging, the most data is with intravascular ultrasound, and the MLA cutoff values are well validated in relation to FFR. So FFR cutoff values are not effective to indicate treatment, but rather more safer to defer treatment. So let us see this. This is a little study from which we learned that the cutoff value was 6 millimeter square, is where we above 6 can be left alone with medical management, and 6 was the cutoff which was published in Neurointervention in 2007. But then we had some data coming in from the PARC and from the Asia Pacific region, where due to the smaller build and the Asian population had a smaller cutoff value, and a cutoff value of 4.5 square millimeters was suggested. So 4.5, but this is one of the studies which showed there's a clear correlation related to FFR, and the cutoff of 4.5 in Asian population, where above 4.5 can be deferred and less than 4.5 significant in Asian population. But then now with the overall consensus is we can safely defer if the left main minimum lumen area by intravascular ultrasound is more than 6 square millimeters. Whereas if it is less than 4.5 square millimeters, it's an indication to treat. If we have a cutoff between the cutoff values of borderline, which is 4.5 to 6 square millimeters, then one needs to do a physiology, mainly FFR, to decide the optimal revascularization strategy. So there are pitfalls for both intravascular ultrasound imaging as well as the FFR. When we do IVUS, it's important to note the proper angulation of the catheter. It is advisable to do pullback from both the LAD and from the circumflex. You have to note that there may be an overestimation of the lumen area, particularly when the catheter is oblique, when there is a pullback from circumflex into the left main. Further, there may be sometimes a distortion caused by the rotational speed, or there may be extensive calcification, which can sometimes limit the exact measurement of the minimum lumen area. What about OCT imaging? OCT has limitations in osteal lesions, we know that, but even the shaft lesions, the minimum lumen area is not well validated like intravascular ultrasound, and it's only an extrapolation using the IVUS. So FFR, if you have an isolated lesion in the left main, there is no theoretical difference with the virus placed in either branch. It can be measured, but it is recommended to do FFR from both the LAD and the circumflex. However, there are pitfalls with physiology, particularly when you have downstream lesions or multiple tandem lesions in the LAD. We need to be aware to measure the FFR. Ideally, imaging is a better option when you have multiple lesions. The other areas, when you have a total occlusion CTO of the right coronary artery, and you have collaterals which are being supplied from the left, then FFR to the left vein is not reliable. So that is, again, it is important to revascularize the right coronary artery and then do the FFR for the left main. What about the IFR? IFR does not have much data unless we have more data. Though we have a lot of data for non-left main lesions, for left main lesions we still need to have more data. Still, we routinely adopt IFR for left main. RFR and other non-hyperemic indices, a word of caution, there was a recent publication saying that RFR in left main is inaccurate and cannot be relied upon. So ideally, if you have a lesion in one of the vessel, the other vessel can be used to measure FFR. For example, in this case, in the LAD disease, you can use the circumflex to measure the FFR. Similarly, if you have multiple big lesions, which are is a single unit lesions extending to LAD and the circumflex, ideally, we have to consider using an intravascular ultrasound in this situation. If you have tandem lesions, one can also consider treating the distal lesions, and after treating the distal lesions, assessing the FFR to left main can be reliable. Show you a case-based learning. It's a 68-year-old lady with atypical pain and positive stress test. The angiogram shows osteoproximal left main disease, which looks borderline by angiography, and following which intravascular ultrasound was done, which shows area MLA of 4.59 square millimeters. So if you look at the criteria, it is quite significant, but if you look at less than 4.5, particularly in the Asian population, this is a small lady. So we decided to do a physiology FFR for this lady. So important to disengage the guide and use intravenous adenosine infusion. For left main, it is important to follow these steps to do a good FFR, and we found an FFR of 0.81 in the LAD and 0.90 in the circumflex, and we decided to keep this lady under intensive medical management. So to summarize, FFR should be the choice in intermediate left main lesions. Give importance to downstream lesions. Measure FFR in both LAD and circumflex. IVS is particularly helpful when you plan a subsequent PCI, so you can do both the assessment as well as PCI with the same imaging modality. And IVS is dependable and always available of correlation when you have any doubts. And OCT has limitations. Thank you for your patient listening. And this is the message where you measure the IVS. If you have a confusion over IVS, you can always do a FFR to confirm the significance. Thank you.
Thank you. Thank you.
Upendra, can you bring in the discussants, please?
Yes,
And
certainly.
you announce them, please?
We have Vincent, Sofian, Rohan, and Mirvat. I'm sure all of them are there with us. So before I give it to our discussant, I just wanted to find out from Dr. Sangathavellu if there's a very tight, significant, angiographically very critical lesion of the ostium of the left anterior descending artery, and then you see in some of the views the distal left main is also 50%, 60% involved. What will be your strategy?
So if you have a continuous lesion from the left main extending to LAD, and the LAD lesion is critical, then one needs to consider a stent from a left main to LAD. Where anyway, you don't have a landing zone in the left main. So regardless of the significance of left main, one would have to consider a stent from left main to LAD. But in imaging will really help to know the exact extent of disease in the left main.
Good. Now, Vincent, can you hear me?
Yeah.
Yeah. What are your views? Regarding this subject of when do you use FFR in the situations of left main stenosis?
Yeah, I think FFR left main is still quite controversial, and it's there are a lot of confounding variable, and we don't have validation as such from non-left main lesions. All right, in this era, all the guidelines emphasize on the physiological significance of the lesion rather than the anatomical significance, and medical therapy has become the holy grail. But I think the left main stenosis is still the remaining area that we don't know yet how to define and how to perform, especially as the previous speaker mentioned, there are a lot of cases. It's not an isolated left main disease. All right, if it is a discrete isolated left main, it may be easier. But many a time you have osteo-LAD, you have a downstream disease, and more complexly you may have a myocardial bridging, which would affect your FFR interpretation. In that case, you may need to have a DFR, IFR, etc. But we don't have any data to support whether we should leave it alone, depending on the single measurement of the FFR. And the previous speaker rightly pointed out that we have to do both the LAD and left cert FFR pullback in assessing the left main before deciding whether to stent it or not. All right, and also you mentioned about if you've got an osteo-LAD disease, probably you have to find a clean landing zone in the left main. Then of course you have to treat it anyway, and we cannot. And I think the clear message to bring home is we cannot rely on a single measurement of the MLA to stent the left main anymore, because as you're shown in the case, the small lady with a small MLA of 4.5, in fact, it is not physiologically significant.
Right. Sofian, one point, do you use IVUS in all your left main, or do you recommend it to be used every time, or there are some particular situations you would use it?
I use IVUS all the time in assessing left main.
Okay,
and
so
for OCT, you know the problem, especially in assessing osteo lesions, and you may have a distorted image, and we don't have any data on the so-called MLA on OCT. As you know, the MLA measure from OCT is even smaller than IVUS.
Upendra, we could go on to the next talk, and then we could actually have more discussion.
That's right. So let's then go to the proximal optimization technique, or POT. What are the best practices? And let me invite Jim Choo to give us an overview of this.
Hi, thank you, Dr. Cole. Hi, everyone. I'm So happy to be able to share with you my perspective on the best practices in performing the proximal optimization technique. So I have no conflicts to disclose. So in this very short presentation, so let's go through what actually POT means and when we should apply the POT technique. I will also try to present the alternative in a provisional strategy of not using kissing balloon inflation by, again, another sort of option of doing what we call a POT side POT or repot sort of sequence. We'll go through that, and we end with some nuances about how to perform a good POT technique. When you put a stent, as we've seen earlier, across a bifurcation, that stent is sized according to the distal main vessel. When Dr. Olivier Darrimont presented the very ingenious POT technique in the EBC meeting in 2007, the primary intent was try to optimize the stent size at the proximal main vessel. And that is done by placing a balloon that is sized according to the proximal main vessel with the distal marker, as you can see, placed right at the carina. And a technical point here is that you need really at least 6 to 8 millimeters of landing zone of the proximal part of the stent. And this is actually to allow us to perform the POT with the shortest balloon that is available. So what essentially you're doing with this first POT is that you have actually optimized the distal main vessel as well as the proximal main vessel. And by doing the proximal optimization, you reduce the risk of wiring, putting the wire under the struts, especially at the proximal part of the stent. And by expanding the stent's struts at the proximal vessel, you're actually opening up the access to the side branch, and therefore, if you're trying to access the side branch through a distal strut, that actually facilitates and ensuring a higher success of the proper selection of the distal strut. The COBIS-2 registry showed that if you perform POT, it may relate to a better clinical outcomes in terms of target lesion revascularization. Now, POT is not only going to be applied at the first part where you try to optimize the proximal main vessel, it is also applied towards the end of the procedure. Here you see in a provisional strategy, after your intervention to your side branch, perhaps like a kissing balloon inflation, you finalize that with another POT. Even with two stent strategies, you realize that POT is actually applied in at least 2 or even 3 times to try to optimize the results. We know from the earlier sort of data and training that once you put any device across the stent struts into the side branch, if you perform any intervention, you're going to cause a deformation of the main vessel stent right across the side branch ostium. And you can actually correct that deformity by performing a kissing balloon inflation. So you can see that after performing a kissing balloon inflation, you actually correct that deformity at the proximal main vessel, but at the same time, that kissing balloon inflation causes another deformity, which we call a sort of like bottleneck deformity. And the degree of deformation of the proximal main vessel depends on the length of overlap of the kissing balloons that you use. Now, there are some concerns about doing this because when you use 2 balloons to do the final kissing balloon inflation, you're actually causing asymmetric expansion, and that may actually cause some overstretch of the artery as well as the plug, and perhaps you might cause some damage to the stent polymer coating. There are some OCT data to show that the eccentric expansion promotes stent thrombosis because it actually inhibits the new intimal coverage of the struts. So this is the sequence or so-called repot that is actually proposed to be able to deal with a provisional strategy without doing a kissing balloon inflation. So what you actually essentially do is you do a first POT, and then you cross a wire into the side branch through the distal cell, and you just dilate through the cells into the side branch without actually performing kissing balloon inflation. And you finalize the procedure with the final POT. This is a so-called repot procedure. Can it actually correct the deformation at the proximal main vessel? You can see that you have a deformation here. And in this bench study, you see that with just a POT at the main vessel, you do somewhat correct that deformation. So to assess whether this is a viable technique, to instead of doing a kissing balloon inflation followed by a POT, This is the analysis that's published in JACC Intervention. In summary, basically, if you do a kissing balloon and followed by a pod to try to correct the proximal stand deformation, you do correct it somewhat, but it's not as good as doing a repod sequence. You find that the elliptical deformation of the proximal main vessel is best with the repod sequence rather than a kissing balloon and trying to correct that with a pod. But if we talk about malapposition of the struts, both the kissing balloon followed by a pod is as good as a repod strategy, as well as the risk of obstructing the side branch ostium with the struts of the cells. They are probably equal between the KBI pod as well as the repod sequence. So really now we can see the repod may be a reasonable option to a provisional strategy that if you want to do that without performing a kissing balloon inflation, you can see from this experimental data that it still does maintain the circular geometry of the proximal main vessel, and with little disruption to the struts to sort of occlude the side branch ostium. And repod, definitely you could see, is a much simpler procedure and is actually 5 French access compatible. Early clinical data like the Cabriolet registry showed, at least in the last year's EBC meeting, at 1 year, very low TBF rate of just 2%. So let's now look at some of the tips of how you can become a wizard in performing the pod so that all your pod procedure ends with the optimal results. First, let's look at the positioning of the balloon. It's always been recommended that the first pod must be performed with the distal marker of the balloon right at the carina. And so various representation in graphic matters in various manuscripts have proposed that the first pod is done in this manner. But you must understand again, all balloons are different. Different balloons have different cone angles, and the position of the shoulder in relation to the distal marker is very different. You can see that some of them are exactly the shoulder at the marker, whereas some are actually just distal to the marker. So know your balloons when you perform the pod and its positioning. This may be more relevant when we are talking about the final or the second pod. Imagine that you have a deep pod and you place the balloon across the side branch ostium. Even if you cross the wire through the distal strut, there's always some short, small amount of new metallic carina, and you're liable to push the carina towards the side branch and regeling the side branch ostium. And here you can see the visible heart. There's some struts across the side branch ostia. Therefore, in this very elegant paper, actually Dr. Andreasen presented this. I was there at EBC 2 years ago, but we just published this year. And I also want to congratulate Ashok on an excellent editorial commentary on this manuscript. They tried to see what happens if you position the pod balloon at the different positions. So essentially, if you put the pod balloon, the final pod, across the side branch ostium, you can see clearly that you are going to jail the side branch ostium, which becomes narrower. This is actually most obvious if you have a proximal wire crossing. But if you place the final pod balloon proximal to the new metallic carina or proximal to the side branch, you have very minimal jailing. The question is how much proximal? Of course, if you put it too proximal, you're not going to correct the geometrical deformation. If you put more distally, you're going to sort of disrupt the new metallic carina towards the side branch. So really sometimes it's difficult to tell. Some of the new stand visualization techniques may help you, but essentially you try to put the distal marker just before the carina, and therefore you can avoid disrupting or pushing the new metallic struts in towards the side branch ostium. One last thing is the question of people always ask, does it matter what kind of balloon you use, a non-compliant versus semi-compliant balloon? There are data, as Rohan has said earlier, if you perform a pod, if you use a semi-compliant balloon, as you yank up the pressure, the balloon is more likely to expand. And so in this model, if you inflate a semi-compliant balloon, it's more likely to expand, to sort of expand the stand diameter in perhaps a large vessel like a left main to conform to the vessel size instead of a non-compliant which doesn't expand. Now, there are some people who don't agree to this, but I guess if you use imaging to size the pod balloon, if you size the non-compliant balloon well, I think you're going to be okay whether you use a semi-compliant or non-compliant balloon. So ladies and gentlemen, I think we've seen that pod is really very simple, but really crucial step in our bifurcation PCI, whether you're doing a provisional or a two-stand strategy. The first or initial pod is very necessary to optimize the proximal main vessel stand expansion and facilitate your access to the side branch. When you perform the final pot, it is also important because after you do any instrumentation to the side branch, you need to correct the main vessel stent deformity that is often induced by the final kissing balloon inflation. The repot or the pot side branch inflation pot sequence is a possible alternative, but as you can see that if you do a kiss followed by pot, it does not totally correct the elliptical deformity at the proximal main vessel. There are some nuances when you perform pot. You must pay attention to the balloon positioning, maybe not so much during the first pot, but more importantly during the second or the final pot. Know the properties of the balloons that you use. The question whether you should use semi-compliant or non-compliant. There are data for using semi-compliant, but I guess again, if you use imaging, it may not matter as much. Thank you very much.
Thank you very much, Dr. Choo, for telling us about most of the nuances about the pod technique. Let me get to Sophia and Johar. Sophia, how do you find out that the final optimization has actually occurred? Do you think imaging is always necessary, or you think looking at the vessel diameter and doing high pressure dilatation with a bigger balloon is enough? Sophia?
Sophia may not be here. Is he here?
Okay. Is Rohan there?
Hi, yes.
Yes. What are your views?
Look, in conventional practice, not including the left main stem, I use imaging 95% of the time. But apart from that, I don't routinely image all of my non-left main bifurcations. I think a pod is a very important aspect to it. One of the quick practice points is just to make sure you have an orthogonal view when you're actually aligning your balloon mark to make sure you don't encroach onto the carina. But the one virtue of doing imaging is to determine whether you've got a circular or eccentric or elliptical proximal segment, and you can choose a non-compliant versus a semi-compliant balloon, so you can oppose slightly better with a semi-compliant balloon. And I've done that on occasion. But as a routine, I think if you estimate the size of the proximal vessel, you don't have any contrast flow around on the outside of the stent, you find it easy to access the side branch. These are all signs that you've quite adequately done a pot.
So you have enough ways to find out whether the optimization has occurred or not. And whenever in doubt in that situation, you would always like to use intravascular imaging.
That's right.
That's very nice. I think let me invite Takashi to conduct rest of the session. And
okay, thank you. Next topic is kissing balloon inflation necessary in provisional strategy. This will be presented by Dr. Nigel Jefferson.
Thank you very much. Just checking you A, can hear me, and B, you can see my slides?
Yes.
Yes, absolutely.
Okay, thank you very much. Well, thanks for the kind invitation, Ashok, the organising committee. It's wonderful to be here and part of this meeting. These are my disclosures. But before we get on to discussing the use of kissing balloons as a routine strategy in a provisional approach, I really want to make the point and highlight what you've heard. In any two-stent strategy, non-compliant balloons for a final kissing is mandatory to not just optimize the acute result, but it optimizes long-term clinical outcomes. Very important point. Provisional approach, however, is relevant for the majority of bifurcations in an unselected context that we see in the cath lab. And as we've learned from Goran this evening and from the EBC the last decade, the strategy involves stenting the main vessel, size to the distal main vessel beyond the side branch, jailing our side branch wire, then performing a pot, followed by selective side branch intervention. Now, we've learned a lot from the bench, and in this case from John Ormiston, how to apply a provisional strategy to a metallic alloy stent. And really what we're doing is inducing favourable stent distortion by doing a pot, by doing a kissing, and potentially by a repot. but specifically why maybe we want to kiss. As we've seen, we wish to relocate the carina, prevent excessive carina shifting. We want to optimally expand the main vessel stent, particularly proximally. We may want to clear the stent struts from the side branch orifice, increase side branch area, and reduce potential for late thrombus or tissue attachment. What about the clinical data? We're really limited in the left main environment to registry data, but data from SJ Park from Korea shows that routine kissing in a provisional strategy in the left main bifurcation intervention offers no added advantage over non-kissing strategy, with all clinical endpoints shown in this slide. Exactly the same seen from sub-analysis presented late last year from Excel at 4 years, again non-randomized, but no advantage with final kissing in terms of the primary or secondary endpoints of the study with a one-stent approach. Intriguingly, this smaller Italian study from Gianluca Rigatelli and colleagues looking at the impact of different final optimization techniques on the long-term outcomes with provisional left main shows a potential signal for harm with a routine kissing strategy compared to completion with POT alone, with increased late mortality with the kissing strategy. If we look at the totality of data, randomized, registry and randomized trials, looking at the impact of a routine kissing strategy on outcomes, we see there's a heterogeneity in what we see. And you've seen this already this evening from Goran. But if we focus on the studies where there's an adverse outcome with the application of routine kissing, the penalty, importantly, is not the side branch, but it's in the main vessel and invariably late. So if we apply a routine aggressive final kissing strategy to the side branch, the penalty is in the main vessel with high rates of main vessel stent failure late. And it's an important point. But when to selectively kiss, we've got data from the EBC and a consensus document saying when we've got significant residual stenosis angiographically, impaired flow, impaired physiology, or potentially stenosis more than 50% by intracoronary imaging, consider intervening on the side branch with a kiss. So we've got a discrepancy between what we know, what we see, and what we've learned from the bench and the clinical data. So really, at times, routine kissing may therefore be harmful. Why? Comes back to adverse main vessel stent deformation, where it's malapposition, asymmetric ovoid expansion, the potential for abluminal wiring, and obviously inadvertent side branch dissection. There's no standardization of how to kiss on the bench and therefore clinically. If we look at the right-hand panel, this is a micro CT model with a long overlapping in the proximal vessel. And as we increase the side branch angle from top to bottom, we see increasingly more deformation in the main vessel proximally, such that we have this bottleneck effect with excessive ovoid elliptical expansion overstretch. But we have malapposition at the ostial portion of the stent with this strategy. And we know with this elliptical expansion, we have extreme perturbation of endothelial stress and flow parameters. Separately, we routinely anticipate on the bench that we can correct malapposition on the contralateral wall induced by a balloon, even on a distal cell, into the side branch. But in reality, clinically, in a diseased state, particularly with variable stent designs, this may not be fully achievable. And finally, with an angiographically driven PCI approach, there's a potential for abluminal wire location in the side branch with recross, angiographically not apparent, with the potential for catastrophic consequences of the main vessel stent proximally, particularly in the left main with kissing. So it really brings home the relevance of imaging here, OCT, with any high risk or complex bifurcation. Choo has told you about the alternative pot-side-pot strategy published on the bench with Guy Fenet and group showing superiority over kiss in terms of ellipticity, malapposition, side branch obstruction. So in summary, the implications of routine kissing in provisional, it really comes back to late clinical outcomes mostly driven by failure in the main vessel stent. So optimization of the main vessel stent is critical. The major disadvantage of ballooning is deformation of the main vessel stent, which we may not be able to correct with kissing. And personally, imaging guidance is mandatory in any complex high-risk bifurcation. So POT is mandatory in bifurcation procedures. Final kissing is mandatory in all two-stent procedures, but I think, in my view, final kissing is optional in the provisional strategy. POT side POT seems a very viable alternative, but we really, both on the bench and clinically, we need more data comparing a POT side POT with a POT kissing and repot approach. So I'll finish there. I'll thank you for your attention. I'll leave you with this concept. Thank you.
Thank you very much for a wonderful presentation about the kissing. Yes.
Can I recommend Dr. Mirvat coming in for discussion?
Okay. So yeah, before starting discussion, I would like to confirm the kissing technique. Yes. Ideally, we try to select the distal cell when you do the kissing. Yes, and then just demonstrate a very clear result. But in the clinical setting, without OCT, it might be very difficult to confirm the wire position, right? That means routine kissing may not always result in the wonderful result. I'm wondering, right? Are there any comment about the wire position, position of the cell? Yes.
I agree entirely. It's an important point, and if we reaccess the sideband through a more proximal cell, one of the other problems we arise is a neocarina across the mouth and without the scaffolding of the side branch and the other things that we wish to achieve. So you're entirely right, and I think one of the reasons why routine kissing is either neutral or potentially harmful is what we think we are doing and what we think we are applying from the bench into the human context is very different. It can be anything from a proximal rewire as opposed to a distal rewire to potentially abluminal. There are various stages where we can get longitudinal stent deformation potentially. So I think without imaging to show us the sort of things that you're talking about, there's every reason why a routine kissing strategy may be harmful as much as it should be optimal.
Okay,
yes, Mirvat, what are your views on this?
Yeah, I mean, I agree with the speakers, but I think another factor that we need to consider is what is the side branch. So if I have a large dominant circumflex, then yes, there's more weight to this branch, and I would be more inclined to open that strut and do a kissing inflation followed by POT or proximal optimization. And the other thing that I like to emphasize is that complex bifurcations, particularly when it's the left main, I don't think there's a harm in referring it to an expert operator. So if someone is not skilled in performing bifurcation stenting, there's no harm in transferring cases and to somebody with the appropriate expertise and with the appropriate devices. So they have IVUS, they have OCT. So I have seen these procedures being performed in labs where they don't have intracoronary imaging, where they are unable to tell, well, did I cross proximally or did I cross a distal cell? And I've seen it in labs that don't have stent boost or a clear stent that allows you to, even at a cost of radiation, see at least where you are and where your wire is positioned. So that would be my only other message, is that a lot of these are not emergencies. And so a lot of these, we can sit back, refer them to an expert operator and an expert lab that has the equipment that you actually need to perform this.
All right. Any other comment or question from the discussant?
I just had a question for Nigel about the kissing balloon.
Right.
And Nigel, as you alluded to the fact that the problem is in the main vessel and it's late. And is that because we've just been kissing the wrong way? Now we have new modified techniques with sequential kissing in a lower atmosphere. Do you think we would get the same adverse outcomes if we adopted the new technique?
I think in a lot of the cases, we're inducing deformation in the main vessel through various mechanisms, not just the balloon through into the side branch that we're not correcting prior to the completion of the procedure. So there's a lot of data suggesting that the that it's not obligatory. It doesn't necessarily value add, which makes intuitive sense when we're actually deforming the stents adversely. I actually think it talks to technique, optimal technique with short overlap kissing. I think it talks a lot, particularly important bifurcations, and as Mirvat spoke about with the main stem, to using imaging. And I think this is a situation where Dr. Akasaka mentioned of actually defining where we have rewired the side branch. The left main is a very important milieu, big side branch being the circumflex artery. So I think it is technique and it is imaging and it's understanding our stent platform as well. Not all stents are the same.
We should move on.
Yeah.
But I was just going to also comment that the EBC main study has encouraged final kissing balloon inflation. And we just be interested to see those results.
Okay, thank you. So let's move on to the next. Yeah.
Can I ask any question to Dr. Ashok Seth, my boss, from whom I have learned the angioplasty? I am Professor Mirvat, Director, National Institute of Cardiovascular Diseases, Dhaka, Bangladesh, as well as Secretary General of Bangladesh Society of Cardiovascular Intervention. Now, I like to know from Ashok Seth that if I do the provisional stenting and requiring no intervention to the side branch, then there is no question of final kissing balloon. And if I do the main branch stenting, meaning that provisional stenting, and requires the intervention to the side branch, meaning that I shall have to kiss that with the side branch, and there is a final kissing is very much essential. And regarding the double stent studies, I think this double final kissing balloon is very necessary. Dr. Ashok Seth, I like to know.
So your comments are right, and I'll just be brief. The concern about even doing a final kissing in provisional strategy, even though the circumflex or the side branch looks fine, arises from the fact that certainly on bench testing, on in vitro studies, because of low shear stress and impaired laminar flow behind the covered side branch with the stent struts covering it, it's been seen that thrombus formation because of low shear forces and impaired flow dynamics, thrombus does occur behind the stent struts. So the concern arises, and also tissue growth on the stent struts has actually been seen, leading to acute Corey syndromes even a year after a large side branch which had been covered with stent struts. So the approach, and certainly the philosophy in certain minds, is that it's better in a large side branch to just open the struts up to get better laminar flow down the vessel and to avoid any tissue growth over the stent struts, and finally, an easier approach to the side branch. Now, this is why this whole discussion arose out of it. This is why EBC main has encouraged doing a final kissing balloon inflation, even in the provisional stent strategy group. And actually, this is why Nigel covered this area, and I think the philosophy is correct. We still don't know the answers, and we therefore do discourage at the moment, apart from very extremely large dominant circumflexes, we discourage in a routine circumflex going and doing a final kissing inflation in a provisional strategy. That's the answer to the whole.
Okay,
session.
wonderful.
And we go on to the next one, please.
Yeah, next topics will be entitled Optimizing Left Main PCI, which imaging modality and what do you look at? It will be presented by Dr. Junya Shite from Japan, please.
Okay, can you hear me? And see my slides?
Yes.
So thank you very much, Professor Akasaka. And I would like to propose which imaging modality and what do you look at for optimal left main PCI. In left main bifurcation disease, I use OCT, as OCT shows tissue morphology, lesion length, and lumen diameter, and 3D reconstruction of stents precisely. If there is osteostenosis, I recommend IMUS because it is difficult to get clear OCT image with insufficient coronary blood removal. In OCT-guided PCI, there is a slogan, MLD max. For pre-PCI, OCT shows MLD. M means a tissue morphology, and lesion length, L means a lesion length, and D means a lesion diameter. As you know, OCT characterizes tissue components. Fibrous plaque is identified as homogeneous high intensity, And calcified plaque is clear border, heterogeneous, and low light attenuation. And lipid plaque is unclear border, low intensity, and high light attenuation like this. This is an example of calcified bifurcation. This is a circumflex and LAD, and opposite side of carina, there is a calcium in here. And if there is a calcified plaque in opposite side of carina shift may happen after stenting. So load ablation recommended before stentings. So after load ablation, we could make sure the ablation effect by OCT, and after stenting, no carina shift happen and get a good result like this. And also OCT predicts side branch occlusion after stenting. If the side branch angle is narrow and carina is protruding to main vessel, there is a high possibility of side branch occlusion due to carina shift. So side branch protection procedure should be considered. And OCT auto lumen profile display shows coronary lumen profile in all scan area. It will guide stent landing zone and help to decide stent length and diameter. It is a coronary map. In left main trunk bifurcation, stent diameter should be adjusted to LAD diameter, and pot diameter be adjusted to LMT diameter. Also, stent length and pot length must be precise with OCT information. For post-PCI, OCT shows max. M means a stent edge medial dissection, and A means a stent apposition, and X means a stent expansion. So this is example of after giant stent implanted in this lesion, and the OCT automatically identify the bifurcation of side branch diameter of more than 1.5 millimeter. So there's two bifurcation here, and you can make sure the stent apposition condition and also expansion condition. So you can only do the post dilatation in the red area like this. And 3D OCT gives image information such as stent cell figure and location of stent link in relation to side branch orifice and guidewire recrossing position. If we implant stent just size by LAD, remarkable malapposition happen at LMT. It is difficult to recross the guidewire distally because of straight form of the stent. And if the guidewire recross proximally, after KVT, geostrat remains as distal carina. If we do pot with bigger balloon, stent malapposition disappear at LMT, and easy to recross the guidewire across the carina due to the gap of the stent. And if the guidewire is distally, after KVT, geostrats move to side branch site and gets optimal result. And we understand stent link disturbed side branch opening, and stent link did not locate at side branch orifice. We call the link-free type. Optimal guidewire recrossing point is distal cell cross to carina. After KVT, we can get the optimal result like this. And if the stent link locates cross to carina, we call it link connecting to carina type. It is difficult to remove the geostrats by KVT. This is a circumflex orifice, and you can see the stent link at the middle of the side branch. And guidewire recross in this cell, after KVT, struts crash like this. And also by putting effect by balloon, these stent shifted to the proximally, and the stent deformation happened. Normal stent at the carina site. So in this situation, KVT causes harmful deformation. This is another example of link connecting to carina type. This link is here, and guidewire recross in the distal cell. After KVT, stent crash like this. Also by putting effect by balloon, these stents shifted to the proximal and no strut at the carina side. And if the guidewire recross the proximal cell, of course there is a metallic stent remain at this site. So in this situation, like a link connecting to carina type, we propose a novel push-pull method for removing the side branch geostrat. The concept is if there is a link is here, intentionally recross the guidewire to the proximal cell, and the wire balloon inflated like this, and push strongly to forward the stent protruding to the side branch site. And after KVT, you can see the wide open of the side branch like this. So this is another example of a link connecting to carinotype. So guide wire recross in the proximal cell and wire balloon inflated like this and pushed strongly. And after KVT, you see this stent strut folded to the diagonal branch site and get the optimal result like this. To achieve the balloon push method, strong backup force is sometimes required. So LMT bifurcation, balloon anchor to the LAD stent, and while balloon inflated and push strongly to the circumflex like this. So this case, before push, you see the stent strut in here and link is here. So intentionally guide wire across the proximal cell. After pushing method, this stent shifted to the distal like this. So you can get a good result like a side branch opening. So I think balloon push technique under the 3D OCT guidance is feasible and useful for removing a gel strut over side branch orifice if the stent link is located at carina. 3D OCT is useful to guide optimal stenting for bifurcation. OCT will guide LMT bifurcation PCI with MLD max and 3D. Thank you for your attention.
Okay, thank you very much for wonderful presentation by 3D OCT image. Yes, yeah. Nobody knows what we did really without OCT image, but you showed very clearly our strategy, right? Our procedure result, right? So, any question or comment from the discussant, Vincent or Sofian or Rohan and Mirvat? Any comment or question?
Yeah, may I have one comment about the balloon stop type, balloon push technique?
Okay.
So personally, I think stop and pullback technique is only effective for type T bifurcation lesion. It means if the side branch perpendicular to the distal main vessel, also there is no significant lesion around the POC area. So stop and pullback technique could be used. Thank you.
Thank you. It's a very important point. So if there is a parallel type like this, narrow angle, important thing is you should do the pot first and a little bit bend it to the side branch side and then push. You can get the forward also together, like a T shape.
Okay.
Is the balloon for the push technique, are you saying you use a smaller balloon, or is it the optimal size balloon that you try and push through? I would have thought it's a smaller balloon, that you've inflated a smaller balloon and then try to push it through to create a space.
I select just size for circumference size.
Okay,
because,
optimal sized. Okay.
Yeah, but need a strong backup. So we usually do the bunker balloon technique, balloon anchor technique.
Right.
Okay, Dr. Stein, you demonstrated a wonderful case with a main stent strut deformation by after kissing balloon, right? In case with link connecting type at the side branch orifice. Can you speculate the final results of bifurcation lesion stenting by using the OCT?
Yes, we need experience doing like this 3D OCT, but by the pattern of the stent link and cell size in relation to the side branch orifice, we can estimate what happened after KVT. So sometimes we intentionally recross the proximal cell and push, or if the link is free, we intentionally recross the distal cell and KVT like this. So we have some pattern to do this procedure.
So I have a question for you. This is very important for the listeners to be practical around this. Do you do OCT every time you cross into a side branch? Do you do OCT to confirm your wire position, or do you only do it? You know, we are able on even stent boost to see whether we've gone distally or proximally. And if we've gone distally and the balloon sometimes doesn't cross because we know the link connector is there, is it then that you actually start seeing with an OCT, or is just your standard procedure that after wire crossing you're going to look at with OCT? It's very important not to convey that OCT is mandatory to know where you've crossed the wire into the side branch.
Yeah, usually every time I recross the guide wire, I check by OCT, and you can understand that the crossing cell is large. You can understand that balloon recross is easy. So it's a pattern is very, gives important information for bifurcation pattern, I think. So every time I recross the guide wire, I check it by OCT. But in Japan, we use a low molecular dextran or half-selling contrast. You can reduce the contrast dye volume. So average use of contrast dye in my hospital is almost 100 cc for one PCI.
So yeah, thank you very much. I think at the moment only in Japan we have lots of experience of OCT, and it is very important to expand the experience of OCT in case with a bifurcation lesion treatment, right? So if there are no questions, I would like to finish this session and hand to the next session. Thank you very much.
Perhaps I can go back to session 1 again, and I'd like to invite back Dr. Chen Shaoliang to talk to us about the double kissing crush with the best practices from best outcomes. Dr. Chen is obviously from Nanjing and the pioneer of DK crush. Shaoliang, welcome back again after the technical glitch.
Yes,
Welcome
thank
back,
you. I can hear you very clearly. Huay and Ashok says, can you see my slides?
Yeah, we do see your laptop.
Okay, good. I think.
Yeah,
it's opening. Now can you see my?
Yes, the PowerPoint is opening. Yes, we can see that.
Good. Yeah, it's a good sign.
It's a good sign. It's a good start.
Yeah,
yes,
I'm so sorry for.
Yeah,
I'm sorry. I'm so sorry for delay. So once again, thanks Huay Ashok to invite me to present DK crush study step by step. Also, I'm very happy to see all my dear friends on the screen. So first of all, I'd like to show 2 cases, including in my DK crush 5 study. The right panel shows 1 patient after treated by provisional sliding technique. However, at 6 months follow-up, because patient presented a very severe unstable angina, so repeated angiography show very good pattern of stent from right to left main, but very critical stenosis as the ostium of the circumflex. So this is one of the typical cases to show why there is so high rate of TLR for complex bifurcation treated by provisional sliding technique. So the next case is a left main Medina 111 bifurcation lesion. After DK crush technique, by 30 months follow-up, there was no any sign of incident stenosis. Also, patient was very happy about chest pain free. So a few months ago, we just published our definition to trial. It's a multi-center randomized comparison of 2 stent provisional stenting technique for patients with real complex coronary bifurcation lesion defined by our definition criteria. So this is a study designed to show 325 patients in the provisional group and another 328 patients in the 2 stent group. The primary endpoint was 1 year TLF tight lesion failure. Safety endpoint was a 1 year stent thrombosis. But angiographic follow-up was scheduled at 13 months, 1 month after clinical follow-up, but it was optional. So at 1 year, so from the Kaplan-Meier survival, you can see 2 lines separate each other immediately after the procedure. At the early stage, it was because the high rate of target vessel myocardial infarction after provisional stenting technique. Usually after 6 to 7 months follow-up, increasing rate of TLR in provisional group. So right now, I'd like to share my case. So before my introduction about the standing technique, so can we vote for the standing selection? Ashok, can you calculate how many percentage of attendees to prefer provisional standing technique, and how many percentage of friends agree to use the two-stand technique? This is my case. The patient was only 49 years old. He presented stable angina 6 months ago. So 4 weeks ago, he suffered from unstable angina. Angiography showed normal right coronary artery, but the epicaudal show confirmed the very diffuse lesion from distal circumflex. So it's a typical Medina 111 left main bifurcation lesions. So let's start it from GK quashi technique. As usually, we need to deploy one balloon in the LAD and another long circumflex scan from the middle part, sir, to the distal left main. With very short protrusion, usually 1 to 2 millimeters. So after standing circumflex, we need to do multiple balloon quash, because the first balloon diameter was adjusted according to the proximal diameter. After that, we need to use another large.
Could we have the microphone off? There's a microphone which is on. I think, Dr. Cole, your microphone is on. Could we have it off, please? There's a disturbance.
Yeah, can you hear me?
We can hear you. Please go ahead. We can hear you.
Okay. Yeah, after first balloon crash, we need to use another 4O non-compliant balloon to complete the crash. The protruded stent into the left main. So for this case, the first balloon for crash was 3 millimeters in diameter. The second balloon was 4 millimeters in diameter. And for any steps of balloon crash, usually we do not remove the circumflex wire. After balloon crash, so the original circumflex wire serves as a roadmap to guide the access of the third wire into the circumflex. So usually we need to at least 2 views to make sure the rewiring from the proximal cell of circumflex stent. As I showed, using the still image to show the distal segment of third wire just across the proximal cell of circumflex stent. So after that, we have to do first kissing balloon inflation. But the key point for kissing balloon inflation is as short as possible of overlapping of 2 balloons in the proximal main vessel. Here, I highly recommend, maximally 2 millimeters overlapping of 2 balloons. After first kissing balloon inflation, we still kept the circumflex wire and use a long stair crossover from proximal ID to the osteo left main. Just before the inflation of the main vessel stent, we have to remove the circumflex wire. After stent inflation, so we need to use another large non-compliant balloon to perform part technique. So after first part, we need to secondly rewire circumflex. As usual as always, we recommend rewire from the proximal cell of the stent. So once we successfully rewire circumflex, so we have to perform second kissing balloon inflation. So always, we recommend as short as possible of overlapping of 2 balloons in the proximal main vessel. After kissing balloon inflation, this is a figure to show the final part technique. So it's a typical part kissing repart. I think the sequence is very important. But the reason for why we need to perform kissing balloon inflation with high quality. So I provide 2 images to show different patterns of kissing balloon inflation. Left part shows 2 balloons overlap each other in very long segments in the proximal main vessel. On the right panel, two balloons overlap each other very short in the proximal main vessel. Also, another point is why we need to do pod technique, because after kissing balloon inflation, the proximal rim of the main vessel stem will become distorted. So this is a key reason for performing final pod technique. So finally, I'd like to finish my presentation using this cartoon to show how to do DK quashi technique. So basically, we need to wire two vessels and to shoot the side branches stem shortly into the proximal main vessel. After balloon quash, we need to rewire from the proximal cell of the side stem to perform appropriate kissing balloon inflation. After that, final port was the last step to repair the distorted main vessel stem. Thanks for your attention.
Thank you very much, Shao Liang. I think the world has really learned a lot from your work on DK crush. One of the things that's always intrigued me is your DK crush 3 study, that your DK crush can be so much better than cuboid stent in the left main bifurcation lesion with regard to revascularization, with regard to myocardial infarction, with regard to stent thrombosis, even up to 3 years. So what is it that the DK crush offers over a cuboid stent technique in the distal left main bifurcation PCI, you think?
Yeah, exactly what you know. Cuboid stent technique has some problems. The first one is a napkin problem after kissing balloon inflation, particularly for wide bifurcation lesions. It means even we perform final kissing balloon inflation because of a very long new carina of the culotte technique. So I think it will be problematic to induce high rate of stent thrombosis. Same thing is that even we perform final kissing balloon inflation for culotte stenting technique, it will still be very difficult to make sure stent strut very closely to the carina. So it means it will be a large gap between carina and stent struts. So I think these are two key points for high rate of stent thrombosis, restenosis of the culotte stenting technique.
I'd like to invite Ravinay and to take the comment on DK crush as a technique.
I'm just going to ask Shaoling, before they come in, I'm just going to ask 2 practical points again for the audience. You've said the proximal crossing, which is well understood when you cross the first time, the wire on the first time. Now, in the second time also, you've emphasized that you cross proximally. And I was just going to ask you a very practical bench type test question. While it's well understood why it's useful to cross proximally to the stress the first time so that you don't go behind this crushed stent, once you've expanded that, once you put the second stent, the main branch stent on, the second crossing, you're shifting more and more metal towards the carina by doing it proximally. And if you went mid or distally, you perhaps would have less metallic carina without going behind the stent struts because you've already done a kissing the first time around. So I want your comments on that because I tend to go more mid rather than proximal during the second wire crossing.
Yeah, I think this is a very great question. Actually, wiring from the proximal cell of the balloon quash is totally different from wiring from proximal cell of the stenting main vessel. To be honest, for secondary wiring, actually we always rewire from proximal to middle cells.
Right. Yeah.
The reason why I always recommend from proximal cell is that even we deploy the main vessel stent, still there is a gap between side branch stent struts and the carina. So if we tell our audiences, okay, you can rewire from any cell, I think it will be problematic to misrewire, right?
Yeah, but second rewire can be done through the middle struts.
Yeah, exactly. I think so.
Okay, go on to Ravinay.
Yeah, look, thank you. Charlene, you're the master of this technique, and I think it's the credit to your technique is the system that you've developed to make sure that operators know what steps to take to address this bifurcation. So if you're doing 2 steps and you're doing DK crush, the evidence, and when I do a DK crush, I'm compelled by the fact that I know that this technique is superior to other bifurcation techniques. And so in my mind or my fellow's mind, they're using this technique. They've got it mapped out. They've drawn pictures, from your papers on the wall to try and understand how to do this technique. So, which is really important. And I think that's part of the success that you've endured, is to make sure that people approach the bifurcation systematically. So that's really important for the audience, a systematic approach. The second thing, and I think Ashok alluded to this, was the proximal cross. I mean, usually in the bifurcation, we cross distally, but in your technique, it's slightly different because we're approaching the cross proximally. Could you just articulate for the audience the importance of wire crossing in the proximal struts? I mean, I think that's important to understand how you remodify that.
Oh, thank you, Ravinay. I think for provisional technique, because we study from main vessel, so it means after studying main vessel, when we rewire side branch, so it's very important to rewire from distal cell. But another story for provisional stent technique is that even we perform part technique after provisional stenting technique, probably for some case, there is a slant of sky as the ostomal side branch. It still will be very difficult to precisely rewire from distal cell. For DK crush technique, we study from side branch. So why we always recommend to rewire from proximal cell is to induce very good coverage of carina by stent struts. I think this is a key point. Another point is that probably it's beyond my knowledge, but I'd like to share about the provisional stenting technique. I think, as Grant, my good friend, I totally agree with all the points he presented. But for provisional stenting technique, if the provisional is crossover to provisional with 2-stent technique, I think it could be calculated as a complication.
Rohan, I'll let you have the last word, but let's hear from Sutek.
Yeah, so thank you for this very clear and pioneering works in the DK crush. I just would like to your opinion on this modified Q-lock stenting technique, like the string Q-lock or the mini Q-lock. If you conduct another trial of a DK crush versus this modified Q-lock technique, what would you expect the outcome to be?
Thank you, Dr. Lim. I think it's another story about a Q-lock technique. To be honest, almost 7 years ago, my another Chinese colleague, Dr. Chen, proposed the mini DK Q-lock technique. From my own view, I think it's not exact mini Q-lock technique. After studying side branch with very mini protrusion into the main vessel. So if you want to precisely rewire main vessel from the distal cell, so it's easily to be crossover to mini crush. So that's a problem. I think why there is so far no clinical report about the mini DK Q-lock. I think probably this is a technical problem. So personally, I refuse to use any kind of Q-lock technique.
And your comments?
Story.
Okay, go ahead.
I'm sorry. Another story is that, just before publication of our definition 2 trial, so a few reviewers asked me, why do we recommend Q-lock and DK crush technique as a two kinds of two-stand technique in our study. I said because I don't like mini DK cool-off technique.
So I'm going to leave the final comment to Goran. So is your philosophy now being challenged by Xiao Liang? Is there complications to put in the second stand, you think, after your provisional approach?
No, thanks for that comment. Of course, as I said, bailout stenting is really so rare that I don't think should be taken as a major variable in deciding on strategy. I believe that everyone attending this excellent session should learn how to do provisional. After that, for 10% of lesions which may require upfront two stents, they have to decide with experience and personal preference, T, TAP, culotte, or DK crush. For me, every option is acceptable, and I believe that by systematically putting stent in the ostium of the side branch, those patients are really 10 to 15% of total population, and I'm not sure that we should promote DK crush as first technique in the left main PCI. I mean, Xiao Liang is a very good friend of mine, but I think we speak the same language. Unless it's really 10 millimeter or longer diffuse disease of the circ, I would never stent circ first.
So Xiao Liang, the question now goes to you. Are you strictly doing your DK crushes in only the one with the definition criteria who fit into the definition criteria? Are you, or do you believe in a two-stent strategy for a much wider application than just the 10, 15% or 20% who may just meet the definition criteria?
Yeah, I agree with your first comments, but I disagree with the second comments by audience. Very similar to what Goran said, I think provisional standing technique is very effective for almost 70 to 75% of all bifurcating lesions. So definition criteria, I think, is the first criteria to separate simple from complex bifurcating lesion. From our previous definition trial, real complex bifurcating lesion accounts for 1/3. So of this complex bifurcating lesion, we have to define which kind of two-stent technique works well. So I think DK crush is not firing provisional standing technique in the community of bifurcation. I'd like to say for some very complex coronary bifurcating lesion defined by definition criteria, I think DK crush is the first option. So in my center, also in the mainland of China, I always recommend we have to stratify any kind of bifurcating lesion according to the definition criteria. Finally, my point is that one weapon is not sufficient for all enemies. We have to become the master of different kind of bifurcation standing techniques. Thank you.
Thank you very much. I think it was wonderful insights from Xiao Liang. I would like to pass on the chair to Dr. Michael Lee, who will take us through some very interesting, challenging case.
I mean, that was a great summation from the two of the masters. I thought that was conveying same thoughts, simple technique for simpler and non-complex patients and complex techniques for highly complex patients.
Yeah,
great.
Exactly.
Thank you, Xiao Liang. After all these practical pearls and with the masters answering all our dilemmas, I think we need to come to some real challenging cases. I know we are far behind schedule, so please, with the speakers, commentators, please keep to the schedule.
Michael, I think there are two cases, so we may not be far behind schedule.
All right.
Okay.
All right. So we might start with the first case right away. Dr. Rajesh CT is going to lead us to the first challenging case on the bifurcation, left main bifurcation strategy. Rajesh?
Well,
okay, great. Go ahead.
Hi. Good evening, everyone from here in India. Thank you, Dr. Michael, for giving me this opportunity. So I was listening very, very attentively to all the discussions, and I was picking up cues from various discussions that were happening, and especially the the talk of Dr. Sangetuvilu and what imaging or physiological testing modality should we be using for the left main bifurcation lesions. And I guess my case demonstrates the various clinical dilemmas related to both clinical decision making as well as the use of imaging and physiological testing in left main bifurcation diseases. So clinical background is important because many a times the decisions that we take on cath lab are have a cue from what we know from clinical history. So this was a 50-year-old hypertensive diabetic gentleman with a little bit of diabetic nephropathy. He presented to a remote hospital with non-ST segment elevation, myocardial infarctions, troponins were elevated, ejection fraction was around 32 to 35%. He was transferred to our hospital for advanced management and in-hospital course. The patient had LVF, ongoing angina, recurrent runs of non-sustained ventricular tachycardias, and the blood pressure was to be supported on vasopressor support. His present serum creatinine was 2.1, and we took him up for revascularization. So as you can appreciate here, it's a left dominant system. The criticality of a dominant circ is beyond doubt. There is a significant tight lesion at the ostium of the circumflex, which is dominant in nature. And from that circumflex, a very high obtuse marginal, which is also quite large in size, is coming out. The left main, of course, appears to be severely diseased in this view. The ostium of the LAD, there is significant disease. And beyond that ostium, there is another tandem lesion in the middle part of LAD, which also needs a little bit of evaluation. So in a different view, we see here the left main was clearly diseased here. The disease was starting from left main. And there was this intermediate looking lesion in the tandem lesion, little away from the ostium of the LAD. So we wanted to define the criticality of circumflex was pretty straight shot, but we wanted to define the criticality of the LAD lesions as well as, individually the ostium of the LAD lesion as well as this tandem lesion in a little distal part. So the two questions that were in our mind was which imaging modality we should use here for left main and LAD. And for the LAD and left main, both the lesions, or which physiological testing which should be using it, or should we be combining the imaging as well as the physiological testing. So we voted for IVUS as our imaging technique precisely because the hemodynamics was unstable. We did not want to push in too much contrast here. In left main lesions, IVUS, we are more comfortable with the use of IVUS than with OCT. And for the physiological testing, we chose for the LAD, we chose IFR, because again, because of the hemodynamic instability, we did not want to push too much of hyperemic agents into the patient and cause further deterioration of that hemodynamic instability. As well as we had two tandem lesions in the LAD, and without giving any hyperemic agents, the value of FFR in pullback techniques and try to give the individual significance, physiological significance of both these lesions is a little superior to IFR. So we chose IVUS and IFR as our strategies for physiological testing and intravascular imaging. So as you can see here, the IFR values across the LAD lesion, it clearly showed two step-ups, one at the level of the distal lesion, the distal tandem lesion, another at the level of the ostium, and the IFR values were 0.7 across when measured across both the lesions, and when measured across just the ostium of the LAD, they were 0.85. So both the IFR values were significant. So we were fairly certain that both these LAD lesions were physiologically significant. The same was proved by the IVUS images. The distal lesion, the tandem lesion, was also having a lot of plaque. I would just skip through for the sake of time. Coming to the ostium of the lesion, the ostium that was not looking too tight disease, we actually saw that the disease in the ostium was pretty critical. And there was a jump as soon as the catheter reached the ostium of the LAD, there was a jump into the left main, and in still images, we could see almost a 270-degree arc calcification in the ostium of the LAD. So ostium of the LAD was critically diseased. This was not an angioplasty we could have gone straight away. Rotablation was probably required in the ostium of the LAD. We would come to that, what we did, but at this point of time, looking at the images, the still images here, the 270-degree iris calcification, some sort of plaque modification was supposedly required here. The catheter, IVUS catheter here, could not really cross the circumflex ostium for the first time. We pre-dilated with a balloon. We kept the wire in the high OM to protect it. And after that, we repeated the IVUS in the circumflex, which again showed what we had seen in the angiogram, a critical disease with almost the same kind of picture, 180 degrees calcification. So the left main disease was also there, and the MLA of left main was 5.6 square millimeters. Now, the extensive calcification of LAD and circumflex ostium, the patient was a little hemodynamically unstable, but the issue was that we were a little wary of using rotablation in this particular case because it was a bang ostium disease and we had to start rotablation in the left main. There were some concerns about damage to the circumflex wire. We did not want to take out the wire and start the rotablation in the left main because the circumflex ostium was critically diseased. So at that point of time in cath lab, we decided against rotablation. We used flextome for both LAD and circumflex lesions, and post-flextome, we decided to go for two-stent strategy. Of course, two-stent in bifurcation, but in LAD, we implanted the first stent in the distal part of the LAD, covering the distal tandem lesion, a 275-33, followed by deploying the circumflex stent protruding into the left main, and another 4x8 non-compliant balloon positioned in the LAD for crush technique. We went for a simple crush technique here. After the deployment of the circumflex stent, the wire was taken out. It was we crushed the stent of the circumflex with that 4x8 millimeter balloon, deployed the LAD stent from the left main to the proximal ostial LAD, covering overlapping with the distal LAD stent. We post-dilated the entire LAD segment, as well as performed the first pots to the left main, recrossed the wires, opened the struts, and we did the second parts with a 5x8 millimeter in the ostium of the proximal, the shaft of the left main, followed by kissing. And this was the final picture of the angiographic views. The IVUS pullback from LAD and circumflex showed reasonable results. The MSA in the left main was 14.9 millimeter squares now. In the LAD was 9.4, in the circumflex was 11.8, and these were the final pictures. So I use this case to highlight the importance of the decision making in left main, in the left main bifurcation with multiple tandem lesions in LAD, the use of IVUS versus OCT, FFR versus IFR, and the question to rotablate or not to rotablate and to use flextome here in excessive calcification lesion can be questioned and debated, and I would like to have the opinion of the House on that. I thank you for your attention.
Michael, you need to unmute.
Sorry, that's a great case. So IVUS and IFR guide finished with crush stenting, circumflex left main after using the flextome balloon. So I would like to hear the comments from our discussants. Is Dr. Eastman there? Eastman, are you here? If not, maybe Viraj. Viraj, would you agree to use the IVUS and the IFR to plan your strategy to interrogate the lesion?
Yes, this is a good case for showing this uses of the imaging combined with the visualistic for the evaluation of the multiple region or complex region of the left main. And I agree to use the IVUS in case of the impaired renal function like this case. And of course, I think the IVUS give adequate information for prepare the lesion and for the selection of the rotator versus the flextome. If the bifurcation lesion involve both the side main branch and the side span, it is quite difficult to obtain the rotator since you should save the Y in both branch. And for the final sending, using these two sending, and in case that the complex one and you would like to shorten the procedure, I think crushing stent still have a role.
Well, frankly speaking, with such a calcified osteo-LAD, osteolate circumflex, a big vessel, my choice will probably go for the shortwave balloons. Actually, if you want to, if you want to keep the wire, otherwise, big vessels, I will go for orbital atherectomy instead of rotablator because you know the bird is too small for this kind of big vessels. I don't know whether you have the shockwave balloon available or the OAS available.
Unfortunately, it's a public sector hospital. We still don't have either the orbital or the shockwave as of now.
I see. But the final result was very nice, but even with the flex tone, so very nice.
If I may say, I mean, we were aware while using FlexTome, since it was a case we could not have abandoned midway, we had to. So I would say that it was a little, non-indicated use for FlexTome here because the FlexTome in a heavy calcification lesion can sometimes, the blades can get trapped in the calcium and they can cut. So it was a relative contraindication to the use of FlexTome. So we actually went ahead, tried to do it gently and pray. But I would like to know the opinions of the house if FlexTome, they have used FlexTome and FlexTome can be used in calcified lesion, sort of off-the-label indication.
We have been using FlexTome for even very calcified lesions, just not to inflate to too high pressure. Miraj, what's your opinion? What's your experience?
Yeah. I also agree with that. The use of the FlexTome in the calcified lesion, you should avoid the high pressure, since the FlexTome itself is not tolerate well to the very heavy calcified toughness lesion. Sometimes it can distort the blade as well. But some of my colleagues postpone the hypothesis that the FlexTome may make like a marking on top this calcified lesion and be prepared for the further use of the high pressure balloon with the NC balloon combined with the first FlexTome. May be helpful in this highly calcified lesion.
I was just going to bring one important point, can I? And that was for Shaoling. Shaoling, I hope you're still here. A lot of people have modified your technique to a single kiss strategy, as you would have noticed. So you crush you just have a minimal protrusion, and you crush the stent, and then just put another stent over it, and just go in proximally. Because once you've just got a minimal protrusion, as you do the first crush, you haven't got a double layer. You still got an open area. And if you put a second stent, the main branch stent, you can still go proximally as you have still a single stent to go through, a single layer of stent to go through. You know this. And this is called the modification of a double kiss crush to a single kiss crush. That is practically what Rishi did. Now, what are your comments on this modifications that you see happening all around?
Yeah, I don't think classic crush works well, even the protrusion is very short. So here, can I have my comments? Yeah, Dr. Seth, could you show your final IWAS for proximal RAD again? Yeah, I think it's a real complex distal left main bifurcation lesion, calcified by Medina 111. Yeah, final IWAS for proximal RAD. For proximal RAD. This is This is for circumflex. This is not RAD. Okay, left one is for RAD.
This LAD.
Yeah, ostium of RAD. Yeah, right here. No, a little bit forward. Yeah, here. Okay.
Yeah.
No. Yeah, don't move.
Yes.
Yeah, here. You can stop here. So my comment is that this is a very good case with very beautiful results, because Rishi said the minimal stent area in the proximal ID is more than 10 millimeters square, right? From the IWAS, you can see the symmetry index is not good. I think the index is less than 70%. So I guess probably after 7 to 9 months, the patient will suffer incident restenosis as the proximal ID. So Ashok, here is my point. This is why I am reluctant to use classic crush for distal left main. Basically, angiographically, there was very clear classification as a proximal ID and a stent flash. So we have multiple choice to modify the calcified lesion. I think the kissing inflation is very important here. Even after we got the IWAS image for proximal ID, I will like to use a larger non-compliant balloon to dilate the proximal ID, followed by kissing and final port. Thank you.
Right, and we do have ultra high pressure balloons to even optimize even further, even if the cutting balloon's been used.
Yes, fair point.
Yeah, I mean that after final kissing balloon inflation, because we have had the IWAS image, because the symmetry index for the osteo's LAD is not good. So I will use another large non-compliant balloon to post-dilate again.
Right.
All right. Let's move to the second case. Thank you, Rashi. The second case is going to be presented by Pangting He from China, Guangzhou. Are you here?
Yes, thank you, Dr. Lee. Can you hear me?
Please go ahead. Please go ahead.
Okay, I want to share my screen first.
Yes.
Can you see that?
Yes, we can.
Okay. Give me a moment, please. Oh, sorry.
We just don't see your face.
Okay, now good evening, everyone. Actually, now we are on the we are on the Mid-Autumn Festival in China, and as you know, it's a very important festival for family members to be alive. So first of all, my best wishes to you and your family members.
Thank you.
Thank
and
you.
Then,
thank you. You want to turn on your camera as well, Pangting?
Yeah, I don't know. Actually, I try.
Oh,
Let me try again.
All right, if you can. But anyway, please go ahead with the case.
And then let's move on. Okay,
right.
I don't want to waste time on it. And then now let's look at the case. This is 70-year-old gentleman. Actually, this gentleman was transferred to our ER after on-site CPR due to temporary loss of consciousness. And then the ECG at the ER shows the ST elevation in lid AVR and ST depression in precordial leads. And here is the angiogram. And you can see there is a very tight lesion at the distal left main. And also we can see very tight lesion at the ostium LAD and the mid LAD as well. Another view. In this view, we can see almost 90% stenosis at the ostium circumflex. And at the same time, we can see actually the ostium's iron bunch seems fine. And as well, we can see it's a very tight lesion at the distal LAD, almost 90% stenosis. And so this is a patient with left main traffication lesions, which can be classified as Medina 1101. And then the Singh test score for this patient is as much as high as 34. Actually, in the first place, we suggest bypass for this patient, but the suggestion was rejected by cardiac surgeon Cheem. And then we have no choice but to plan a PCI for this patient. And at that point of time, we decided to do DK quash for left main traffication lesion, and then we will do stage PCI for the right. And then I wired the iron bunch after a couple failed attempts to wire the LAD because you can see here there is a very sharp angle between the ostium LAD and the distal left main. So I wire the IM branch first and then dilate the distal left main with a 2.0 balloon. And then after that, I can successfully wire both LAD and circumflex. And then, of course, after that, I can do the pedalation for the mid LAD lesion and the ostium LAD lesion and the ostium circumflex lesion. After that, I did the IWAS check. We can see that actually there was very heavier plaque burden at the middle to distal LAD. And then we can still see there is a plaque burden at ostium LAD even after pedalation. And I was checked for IM branch and circumflex as well. We can see the even after pedalation, we can still see there is a very tight lesion at ostium circumflex. And based on the angiogram and IWAS, we can see that actually the ostium IM branch is fine. So we just move on to do the PCI as planned, because we want at the beginning, we have decided to use DK crush technique to do the left main traffication lesion. And then after I was checked, we still need to keep our initial plan. So I put a stand at the middle to distal LAD first, and then another stand from circumflex to left main. And then I crush the circumflex stand with a 3.5 balloon, and then use a bigger balloon, 4.0 balloon to further crush the circumflex stand. After that, I will wire the circumflex and then do first kissing. And then after first kissing, I deploy a stand from LAD to left main, overlapping with the first stand at the middle LAD. And then after that, I can use balloon. I can use 4.0 balloon to do the second port. And then after that, I can use 2 lung compliant balloon to after I will wire the side branch again. I can use 2 lung compliant balloon to do the second kissing. Of course, after the second kissing, we should do the third port at the left main. And then we did IWAS check. And actually, I think we got a very good result at the ostium LAD, because the MSA, I think we all agree that it is acceptable. But still, we can see some minor malapprehension at the left main stand. So we use the 4.0 balloon to post-dilate the left main stand again with higher pressure. And then after that, we do follow IWAS check. We almost got, I think we got acceptable result in every segment, in stand segment. And then we also correct the malapprehension at the left main stand. Here is the final result, final angiogram. I think the result is acceptable for this patient. And then take a message. Actually, during primary PCI, now we know that STEMI caused by left main lesion often leads to unstable hemodynamics, and immediate perfusion is very crucial. Secondly, IWAS is recommended for left main bifurcation or trifurcation PCI, because we all know that intracoronary imaging tool could provide detailed information, which is very important for decision making. And thirdly, for cases with appropriate anatomy, DK crush could be considered as the first option in primary PCI due to its efficiency and optimal long-term outcome. Okay, that's my presentation. Thank you.
Thank you, Peng Teng. That's a great case. So IVIS guide DK crush stenting for a STEMI patient. Zhenjie, I know you will surely agree with the Peng Teng that you will use DK crush. So what do you think? What do you think? Would you change anything about the case if you are going to do the case? STEMI patient, bifurcation, left main, LAD, circumflex, and then you have to tackle the patient. What would you do?
Firstly, congratulations. It's a challenging case with a great result. So if I do the case, I think from the baseline angiogram, actually AVI ST elevation, and combine the baseline angiogram result, actually the critical lesion is located in distal left main. So I think distal left main is a capital region. And from the spider view, I noticed although it's distal left true bifurcation lesions, but the orifice of a circumflex lesion length is quite short. So according to the definition criteria, it's not a complex definition bifurcation lesions. So if I think another option is to use a provisional standing with a main vessel standing. This is my option. But anyway, our congratulations. It's a fantastic result with a DK crush. I was guided for these critical high-risk patients.
So Junjie, do you usually try to avoid complex stenting in the setting of primary PCI? Or you will actually depends on you take the definition 2 criteria into consideration as well when you are facing with a STEMI patient?
Yeah, I think individualization, depending on the patient situation, comorbidity, and also I think most important is the morphology of the bifurcation lesions.
Okay, great. Can we ask Dr. Mir Jalaluddin as well? Are you here? Are you in the group here, Dr. Jalaluddin?
Yes, he was. But I
okay,
think,
maybe. Yeah.
Could we ask Goran? Goran, is Goran here? Goran's comments on, or is he left? I just saw his. Maybe Goran. Goran, can you hear us? He just left.
Maybe he just left.
Yeah.
So Ashok, what do you think? Would you do DK crush for this patient?
Well, I think I would have avoided DK crush.
Okay.
And would have truly thought that if I could do away with go away, at least certainly provisional would have been my first choice. But I thought that was elegantly done. I thought that the result was great. And I think IVA's guidance is very important. I mean, that's what gives you the final. Actually, decision making should not revolve around gut feelings. It should revolve around hard endpoints. And I think IVA's guidance probably, guides you far better in what your strategy should be as you go along. So I just find that there's a lot more IVA's guidance being done in Asia Pacific than it is being done in Europe for left main bifurcation stenting. And I'm intrigued by that because at the end of the day, those are the hard endpoints that we need to achieve to get the best outcome for our patients. And there's one thing I've got to state while sitting here, and that's for all the listeners. You can't do a substandard job on the left main. If you've got to compete with surgery and believe that PCI is going to be as good as surgery, not just getting the patient out from the cath lab, but not just in the intermediate term, but in the longer term, then there's no question in our minds that it has to be optimized. It has to be the best which can ever be done. And the patient should go out with the best possible results, and that can only come through image guidance. And therefore, give the patient the best if you really believe that the patient needs to avoid surgery and still have the best long-term results.
Yes, I agree. Imaging is really important, no matter it is STEMI, in the setting of STEMI or non-STEMI, or even the more acute situations, cardiogenic shock. When you have to do it, complex stenting, you have to use imaging. So Ramesh, yeah. would you prefer Kulak stenting instead of DK crush in this situation? Or you would also stick to DK crush? Ramesh? We can't hear you. Sorry. Can you unmute yourself?
Okay.
Okay.
I think in the situation of the emergency like this, Hilrat may be more difficult to guarantee the keeping of the Y in the both sides.
You don't want to lose
I don't like to lose it. So I think my idea DK class may be better.
Okay, great.
And then may I make a quick response to your comments? Thank you very much.
Yes, go ahead.
Yeah, actually, in this case, because you can see here, because not only the extreme circumflex, but also the mid circumflex is very severely stenosis there. So that's why, actually, in most cases, I agree with you that I would like to prefer to keep it simple. But you know, actually, in this case, the lesion at the mid circumference was quite high and a little bit long. So I think that's why I decided to use two-stent technique for this trifurcation lesion. Yes.
Yes. I will go for you for complex stenting because it's a long, diffuse circumflex lesion, and it's a very important branch that we cannot lose. So I would probably go for complex stenting. I would probably go for DK crush as well. The only thing I will do more is I probably will use a bigger balloon at the left main. We see there are still sort of a very mild malposition at the end. I will use a 4.5 or even a 5.0 balloon to try to optimize, do a proper port at the end of the procedure. Although we have to know the type of stent, to know the limit of the stent, how big it can go to.
Yeah, one of the points we didn't discuss, of course, is the type of stents which one should use, because at the end, it has 3.5 and got to be 5 in the left main, 3.5 in the LAD. So we need to also understand that the stents to be used should have enough expansion characteristics. While most of these stents, when they expand, they become more rigid because you just straighten up the connectors. But wall ratio changes dramatically, and the drug delivery changes dramatically. The polymer leaches dramatically, and those are the issues that we need to keep in mind when we overexpand these stents. And so one needs to go very deeply into it. And of course, the newer stents have come out for these larger left mains. I was just going to say one I wanted to ask Xiaoling before we actually close, and I know everybody's keen to sort of break off, but Xiaoling, do you have any tips regarding crushing of the stent and the size of the balloon? Do you size it to the left main or do you size it to the LAD? So you're crushing a circumflex stent. What do you actually do?
Thank you. Thank you for your question. Actually, you know, for balloon crush, the balloon should be sized. This is particular for distal left main bifurcation lesion. After the first balloon crush, usually we need to use the second NC balloon adjusted according to the left main diameter. So here, may I have another 2 comments, Michael?
Yes, go ahead.
Yeah.
Go ahead.
The first thing I'd like to say is that before the launch of our definition criteria, I'd like to say don't feel guilty if you deploy 2 stents for any kind of bifurcation lesion. Second comment is that for this case by Chen, this is very, very challenging case, acute myocardial infarction. Even Singh flash looks like according to the definition criteria, Singh flash, this could be classified by complex bifurcation lesion. You know, from spider view, just before the launch, before the taking of the obtuse marginal. So the process. So thank you, Chen, for your excellent final result of the DK crush.
Thank you, Dr. Chen Xiaoliang. I won't be feeling guilty anymore after your
Oh, you had a great case, gosh.
Yes.
You had a wonderful case. I think if everyone agrees around the screen, I would say, not the podium, we are half an hour over time, despite the fact that we didn't want to go over time, but left main topic is such, and the speakers are such great experts that it was just imperative that I knew that we would go over time, because even if we wanted to go from here on, I'm sure another half an hour or 45 minutes of discussion would continue to happen, and people are still logged on wanting to hear more and more. But I think all good things need to come to an end. We would certainly address this on another day, but I think we had some of the greatest people around here. Just want to tell you 3,300 registrants was what happened today. And we spread across 10 hours of time zone from Serbia to New Zealand was 10 across of time zone. Asia Pacific Society of Interventional Cardiology itself, though it's called Asia Pacific, actually Our friends in Saudi Arabia, Kuwait, Bahrain, Dubai, UAE all continue. And now we've got friends in Afghanistan, Iran, Iraq, who are members of APSI. It now continues to New Zealand. So I think it's tremendous for all of us to be together on this podium, to be together for this forum of APSIC webcast, and for together to share, exchange, inform, and educate as we go along in our journey towards propelling APSIC as a major interventional cardiology forum. I thank you all for having taken the time out to contribute to education and science for APSIC.
Thank you.
Thank you.
Thank you all.
Have a good night. And be safe and stay healthy. Thank you all.
Thank you.
Thank you. Bye-bye.
Bye.